Hello friends, today we are going to discuss about the ICU acquired weakness. So ICU acquired weakness is typically generalized symmetrical affects the limb that is proximal more than the distal respiratory muscles, whereas facial and the ocular muscles are spared. Muscle tone is also invariably reduced. Deep tendon reflexes can be reduced or normal. So weakness may originate from the neurogenic disturbances. Critical illness polyneuropathy, myogenic disturbances, that is critical illness myopathy and combination of the both. So we'll see what is pathophysiology. So first is muscle atrophy. The catabolic state of the critical illness with reduced anabolic effector hormone and increased catabolic hormone. Mechanical unloading due to immobilization, denervation explains the pronounced muscle wasting that contributes the weakness of myogenic origin in ICU patients. Such a loss of muscle mass is due to imbalance protein turnover and reduced protein synthesis. Then muscle dysfunction. Several factors contribute to the loss of muscle function during critical illness. That is structural muscle and alteration in the muscle biopsy shows the signs of inflammation and necrosis. Pronounced infiltration of the muscle with adipose tissue and fibrosis is remarkably high proportion of the critical patient. Then microcirculatory disturbance. Microcirculatory changes include vasodilatation, increased permeability, which allow the leukocyte extravasation and tissue infiltration, local cytokine production, and edema formation with increased intercapillary distance. These changes can compromise perfusion and oxygen delivery. Involvement of the edema-induced compression damages the muscle and nerve remain debated. So hypoperfusion may contribute to the neuronal injury, axonal degeneration, and chronic membrane depolarization of terminal motor axons. Then the last is bioenergetic failure. So this insufficient oxygen supply to mitochondria may compromise mitochondrial energy production. However, mitochondrial dysfunction in critical illness appears explained by impaired oxygen utilization due to direct mitochondrial damage, which is further aggravated by inflammation, hyperglycemia, free radicals rather than by impaired oxygen delivery. So, dysfunctional mitochondria not only compromise energy provision but also amplify the production of the free radical and reactive oxygen species, eliciting vicious cycle of micromolecular and organelle damage. Now, inadequate autophagy activation. Initially, increased autophagy was assigned a detrimental role as a contributor to the muscle atrophy. However, it has become clear that this important cellular quality control mechanism is actually insufficiently activated during critical illness, allowing accumulation of damaged mitochondria and other cellular components. So, impaired clearance of such a damage results in degenerative changes, which compromise muscle function and thus contributing to the ICU acquired weakness. Now, the next is membrane and ion channel dysfunction. Sodium channel inactivation is thought to contribute to the rapid and irreversible hypoexcitability and inexcitability of the nerves and the muscle membrane in patients with ICU-acquired weakness. And altered intracellular calcium homeostasis further contribute to the impaired muscle contractility by affecting excitation contraction coupling. Now, central nervous system involvement. Recent evidences suggest that central nervous system involvement with the failure of coordinated repetitive firing within the motor neuron can be very early event preceding electrical failure in axons and nerve muscle coupling. Now about diagnosis. Assessment of the peripheral muscle strain. To diagnose ICU acquired weakness, ideally the clinical quantification of muscle strain should be performed. As patients are often unconscious or uncooperative due to sedation or delirium, such a clinical diagnosis is often not possible or is delayed. So, most widely used technique is the sixth grade Medical Research Council sound score. This score yields the global estimation of motor function, pointing to clinically relevant muscle weakness when below 48 and severe muscle weakness when below 36. However, the differentiation in the higher range is difficult. A modified 4-grade score showed better inter-rated agreement for diagnosing ICU-acquired weakness than classical 6-grade score. The ordinal scale of MRC score limits the sensitivity to detect the more subtle changes in the muscle function. In contrast, handheld dynamometry for measuring hand grip and quadricep strength provide continuous quantitative measure, but the representativeness of global muscle strength has been questioned. The scored physical function in the intensive care test, functional status score for the ICU, then the Chelsea critical care physician physical assessment tool provide information about the patient functional ability but are less commonly used. Finally, 6-minute walking distance assess the functional capacity but is rather used to evaluate how patients perform at discharge and in post ICU follow. Electrophysiological assessment are also used to diagnose ICU acquired weakness and can be applied to the unconscious and uncooperative patient. Although the CIP and CIM shares the features of nerve conduction studies, electromyography differentiation is possible in ideal circumstances, particularly when patient is cooperative and voluntary muscle activation is possible. Single nerve conduction studies have shown to promise as alternative for time-consuming full electrophysiological studies. For differential diagnosis of CIP and CIM, in uncooperative patient, direct muscle stimulation shows the normal muscle excitability in CIP and reduced muscle excitability in CIM. However, expertise is not widely available and differential diagnosis is further complicated by high occurrence of CIP and CIM. A variety of imaging techniques have been evaluated to assess muscle mass as surrogate of muscle strength and some of which also visualize the muscle quality. Of this, ultrasonography is considered most promising. Although ultrasonography allows the quick and repeated bedside evaluation of measures of muscle quality and quantity, it may underestimate the muscle and the protein loss. The clinical relevance also remains to be determined. Computed tomography and magnetic resonance imaging can accurately and reliably detect the infiltration of the muscle by adipose tissue and quantify the fat-free muscle mass, but are expensive and required staff and software and are logistically challenging. Furthermore, the CT exposes the patient to high level of radiation. Several of these limitations also apply to the dual energy X-ray absorptiometry and neutron activation analysis that assess the body composition. Bioelectrical impedance measurement also assess body composition, but results are affected by edema, skin temperature, and position. Finally, nerve and muscle biopsies can provide important information and have increased mechanistic understanding, but are invasive with potential for complication and require specialized expertise for obtaining sample and interpreting findings. So biopsy analysis may allow the differential diagnosis for CIP and CIM, but the now biopsy is too invasive for routine clinical use and hence is no longer advised, except in the context of scientific research. Now, assessment of the respiratory muscle strength. Volitional testing for global respiratory muscle strength via maximum inspiratory and expiratory pressure and of diaphragm strength via transdiaphragmatic pressure is again limited by requirement of awake and cooperative patient. Measurement of transdiaphragmatic and endotracheal tube pressure in response to phrenic nerve stimulation can circumvent this problem but is invasive and requires magnetic stimulation and is technically difficult. Also, imaging techniques are being used. Chest X-ray have low sensitivity and specificity, and ultrasonography has limited value during assisted breathing. So this table is the representative of the diagnostic modalities that we have discussed and which can be used in the assessment of the peripheral muscle. So first is MRC sum score, then handheld dynamometry, then scored physical function in intensive care test, then this 6-minute walking test, and this Chelsea critical care physical assessment too. Then next, the electrophysiological studies can be helpful in diagnosis like EMG and NCV and direct muscle stimulation test. Further imaging study can be useful like ultrasonography and CT. So CT is the highly accurate and highly reliable. It is valid in patient with the severe fluid retention. MRI is also highly accurate and highly reliable. Dual energy X-ray absorptiometry can also be useful for diagnosis. Neutron activation analysis is very accurate and valid in patient with fluid retention. Then the other test that we can use is bioelectrical impedance and measurement and nerve and muscle biopsy. Now the diagnosis of ICU-acquired weakness in assessment of the respiratory muscle. That is maximum inspiratory and expiratory pressure and diaphragmatic pressure. The non-evaluation functional tests include transdiaphragmatic pressure in response to bilateral twitch phrenic nerve stimulation, endotracheal tube pressure in response to bilateral phrenic nerve stimulation, and sometimes imaging that can be used like chest X-ray and ultrasonography of the diaphragm. Now, this is the difference between critical illness polyneuropathy and critical illness myopathy. So, in critical illness polyneuropathy, the C amp amplitude is decreased. And in critical illness myopathy also it is decreased. Then CAM duration will be normal in polyneuropathy but increase in myopathy. SNAP amplitude will be decrease in myopathy and normal in myopathy. Then nerve conduction velocity will be normal in both condition. EMG at rest will show the fibrillation potential and positive sharp wave in both conditions. Then this MUP, that is motor unit potential of voluntary muscle activation, will be of long duration and high amplitude and polyphasic in the critical illness polyneuropathy, and short duration and low amplitude in critical illness myopathy. Repetitive nerve stimulation will show absence of decremental response in both conditions. Direct muscle stimulation will show the normal muscle excitability in critical illness polyneuropathy. But in critical illness myopathy, it shows the reduced muscle excitability. Nerve biopsy will show the primary distal axonal degeneration of sensory nerve fiber. And nerve biopsy will be normal in critical illness myopathy. Muscle biopsy will show denervation atrophy of type 1 and type 2 muscle fiber. But in critical illness myopathy, the spectrum of abnormalities will be myofiber atrophy, autoregulated fiber, necrosis, fatty degeneration, focal and diffuse loss of thick filament. Then risk factors are first group of risk factors are not modifiable. The severity of the critical illness is the important determinant, and the higher severity of illness score, sepsis, inflammation, multiple organ failure, as well as longer duration of mechanical ventilation and ICU stay. The relationship with mechanical ventilation could be reciprocal, given that prolonged ventilation increases the risk of isoacquired weakness and diaphragmatic dysfunction, which vice versa increases the risk of prolonged ventilation and failed kidney. Another illness-related risk factor is high lactate level. Further, higher risk of weakness may apply to the female than the male, older as compared to the young patient. Premorbid obesity was found to be independently protective factor against the development of isoacquired weakness and against the muscle atrophy. Some risk factors are modifiable. These include degree of hyperglycemia that develop in response to the severe stress of critical illness, the administration of parenteral nutrition, but also several drugs that are used to treat critical illness patients. For example, dose and duration of vasoactive medication, mostly beta agonists, and are associated with the high risk of ICU-acquired weakness. The meta-analysis showed that the use of corticosteroid has been associated with risk of ICU-acquired weakness in heterogeneous patient population and when focusing exclusively on the patient with sepsis. However, one study suggested a protective effect of corticosteroid when hyperglycemia as a side effect was avoided. The reported adverse relationship between use of neuromuscular blocking agent and muscle weakness remains uncertain. The RCT comparing 48 hours infusion of cisatracurium with placebo, both under deep sedation in ARDS patient, did not observe significant impact. However, 48-hour infusion of cisatracurium with concomitant deep sedation tended to increase risk of ICU-acquired weakness as compared with the absence of routine neuromuscular blockage and lighter sedation target with significance reach for weakness on day 20, but not for weakness present on the day 7 and at any time through day 20. Also, when co-administered with the corticosteroid or infused for more than 48 hours, neuromuscular blocking agent may promote weakness. Certain antibiotics, including aminoglycoside and vancomycin, has been independently associated with ICU-acquired weakness. The association between sedative and weakness may be indirect, as separating effect of sedative from those of sedation-induced immobility and bed rest is difficult. Continued sedation is thought to have more pronounced effect on muscle atrophy and weakness than the patient is conscious but immobile in absence of sedation. Now, the acute and long-term consequences. So, short-term consequences include increased ICU mortality, increased ICU length of stay, and in-hospital cost, increased mechanical ventilation, extubation failure, and swallowing disorder. Long-term complications include ICU mortality, decrease uh, prolonged prolongs the process of the discharge, decrease physical functioning, increase rehabilitative length of stay, and discharge to other hospital and rehabilitative center. So preventive and therapeutic measures is avoiding hyperglycemia, tight glycemic control, targeting normal fasting level with insulin infusion is compared with tolerating pronounced hyperglycemia, reduce morbidity and mortality of surgical, medical, and pediatric ICU patients in the context of early use of parenteral nutrition. However, the optimal glucose target remains controversial as largest multicenter RCT showed that intermediate blood glucose level may be safe. Nevertheless, the strictly targeting fasting normoglycemia in surgical and medical ICU patients reduce the risk of developing electrophysiological signs of critical illness, polyneuromyopathy. Achieving normoglycemia rather than administration of insulin explain this lower risk. The polyneuromyopathy prevention, in turn, partially explained the less need of prolonged mechanical ventilation, which suggested the impact of this intervention on clinically relevant ICU-acquired respiratory muscle weakness. Then avoiding early parenteral nutrition. The severe caloric deficit that arises from critical illness associated with anorexia and gastrointestinal dysfunction has been associated with muscle atrophy and weakness. So the muscle atrophy has been regulated as major myogenic component of muscle weakness. Based on observational studies and expert opinion, to prevent muscle atrophy, nutritional guidelines hence advocated early full nutrition, preferentially via enteral route but otherwise supplemented via parenteral route. Major emphasis was put on giving enough protein and substrate for building muscle mass. Indeed, supplementing insufficient enteral nutrition with early parenteral nutrition to caloric target increases the complication and delayed recovery of critically ill adult and children as compared with accepting the micronutrient deficit by withholding parenteral nutrition in first week in ICU. Harm evoked by early parenteral nutrition compromises more ICU-acquired weakness and impaired recovery, longer dependency on mechanical ventilation, and longer stay in ICU. So early parenteral nutrition to caloric targets also did not reduce muscle atrophy. More specifically, early administration of amino acid, but not glucose or lipid, appear to be culprit. Rather than being used for synthesis of muscle protein, amino acid appear to be largely broken down and shuttled to ureagenesis, possibly explaining the lack of benefit in RCT, investigating increased amino acid supplementation. So amino acid also suppress the autophagy in muscle, which has to be mechanism contributing to the ICU-acquired weakness. So minimizing sedation and early mobilization. As mobility increases the risk of ICU-acquired weakness, the early mobilization and physical rehabilitation were tested to reduce the risk. Interestingly, daily interruption of sedative infusion was shown to reduce the duration of mechanical ventilation and of ICU dependency. A more recent analysis concluded that early rehabilitation improved only short-term physical related outcome with low quality of evidence for decreased risk of ICU-acquired weakness as compared with standard care or no early rehabilitation. Then neuromuscular electrical stimulation. Because poor alertness and cooperative cooperation precludes early active mobilization of large proportion of patients, neuromuscular electrical stimulation has been suggested as an alternative. Several mostly small RCT have been performed in critically ill patients. The variable use of frequencies, intensities, and duration of neuromuscular electrical stimulation widely varying outcome, limiting pooling and interpreting data. Although some studies were promising, most recent systematic review and meta-analysis did not reveal significant improvement in muscle strength or dependency on mechanical ventilation and intensive care with neuromuscular uh, NMES as compared to usual care. Systemic review of initially promising pharmacological intervention, such as anabolic steroid, oxandrolone, growth hormone, and the propranolol, immunoglobulin, glutamine therapy, could not recommended any of these for adoption in routine practice. Now, the rehabilitation beyond ICU stay, early intervention to prevent or attenuate debilitating consequences of ICU-acquired weakness are obviously important. Some studies shows that the positive effect related to functional exercise capacity, unlike other, but systemic review could not support the benefit from the post-ICU physical rehabilitation given the low quality of available evidence and heterogeneity. So adequately powered RCTs are needed. Now the conclusion and clinical implication. Muscle weakness is the frequent complication of critical illness with devastating short and long-term consequences, therefore requires prevention and treatment. Prevention seems at least in part possible and as avoiding hyperglycemia, postponing parenteral nutrition to beyond first week in ICU, and has been shown to reduce the burden in ICU acquired weakness. So, early mobilization, which requires minimizing sedation, may be promising, and several ongoing studies are awaited for to further clarify its impact on clinical relevant outcome measures. Further research is also required to design new preventive and therapeutic strategy that can be tested in adequately powered RCT. Based on animal studies, the first interesting candidate to explore could be infusion of ketone bodies or strategies to activate ketogenesis. Thank you, guys.